from now on. So this is the archetypical patient you'll see in New Zealand, Maori or Pacific man with a sore big toe, and that's all he sees. And he takes some Voltaren and he gets back to work and he's happy. This is what you're worried about. This is getting joint damage or developing a tophi. So if you have, and we don't know why some people get bad tophi and some don't, but my 35-year-old Samoan man with his claw hand, he will probably never be able to work again because of that claw hand. Okay, so here's a similar sort of case. Do you remember how this, oh, you didn't see this man walking, did you, Hannah?
No.
There's a thing called the gout limp. And when it's in the big toe, it causes a constraint at the ankle, but not at the knee. And there's a characteristic walk to somebody with gout. And so you see a Maori or Pacific man walk into the office, and they're in quite a bit of pain, but they're controlling it. And they've got this, they're able to weight bear. It's not like they're hopping in. The people who break their ankle or Achilles tendon will hop into the clinic. If they've got a sore knee, they will sort of have a whole body, a Trendelenburg type limp. These people, we joke about it when we teach, but there's the gout walk. I've got a video of it, which I can maybe show you at the end. It's a bit hazardous showing extra things on these talks. So this man had no history of injury, which is interesting because your man had the history of injury. He feels well. He ate mussels last night. He doesn't drink alcohol, and he'd had 2 recorded attacks of gout. And on both occasions, he'd been on diclofenac. And so this is in my clinic. It's a Saturday morning, and this guy smokes 1 to 10 cigarettes a day. So I'm feeling, I've got a waiting room full of patients. I'm trying to not keep anybody waiting. And this guy needs prophylaxis, potentially. And he hasn't been given it before, so I'm feeling slightly embarrassed that, that this hasn't been done, and feel the pressure to initiate prophylaxis. And I'm thinking, how am I going to do this in 5 minutes? Well, at the time, Nicola Dalbeth and I were doing a randomized trial of giving allopurinol during an acute attack. And we found actually you can give allopurinol during an acute attack, although our blister pack's way too weak. There's no hurry. What you want is the behavior change. Get away from the debate about whether you can or can't start. Technically, in most people, you can. The thing is, you want them starting to get into a prophylactic pattern should they need it. And downstairs, I knew the pharmacy had the study pack. So I just said, give this man a study pack 1. I didn't give him any dietary advice or anything, because these people are in a lot of pain. They don't want you fluffing around talking about what they can do and can't do. You get them back for that and do it the next time. So that's the advantage of primary care. You're going to see this guy again. And so you leave that to that point. Okay, I don't know whether you can, have you got a chat line there on your screen, Hannah?
Chat box, yes.
Yeah. Because I don't know, if you could just, oh, there's a, okay, I see the questions there. People were answering, yep.
I can't see you, I don't have questions. I've got.
You can perhaps answer, you can make comments.
There's just a normal chat box where the members of the meeting can write to each other.
Can you ask a question in that?
Oh, I can, yeah.
Okay. Yep. So if you want, I found my chat box. It's not as an icon, but I found it elsewhere. Okay, so there we go. Okay, so he's got pain and redness over the right MPT joint. His vital signs are normal.
Hello, calling from Koha for baby Tahira, just trying to book him in for a 6-week in. Please give us a call back on our 0800 number. I'll find it.
Bruce?
Yeah, the microphone's off, isn't it?
You're on mute, Bruce.
Sorry, I muted myself. Okay, so I talked about his no other painful joints, blood pressure 180 on 120, which is quite high. not uncommon in primary care. I know that will probably freak you out, but I see a lot of people with those sort of blood pressures. They're not going to die tomorrow, okay, unless they've got cerebral signs of malignant hypertension. And you'll be lucky if you ever see a case of malignant hypertension in your careers. I've seen a handful, and they're disappearing because we treat blood pressure so well these days. Blood pressure is one thing that's universally pretty well treated. So let's say we think this guy's got gout. Just go back to, so there's a Tongan man, he's 8 muscles, he's had 2 previous attacks. It came on fairly quickly. He's got pain and redness and no other painful joints. So just think of 5 things, maybe just write them down, 5 things that would make you think he's got gout. I'll just give you a minute to do that. Did you get to meet anybody you didn't know in your rooms?
I didn't meet anybody.
Oh, okay.
I was there by myself.
I think what happened, so about 20 people left when we broke people into rooms. I think they, is that Helen, is it?
Yes.
Yeah, so I think your roommate must have disappeared. So people didn't want the interactive nature of the talks. Or else there's an epidemic of social anxiety, perhaps adverse effect of people being at home. It is one of the problems of a lockdown because social connectivity is very important for our mental health. And one of the things I've found in my work is that people who aren't in contact with their friends and aren't doing recreational stuff and exercise are more likely to have a low mood, which makes sense when you unpack it backwards. But so there are mental health issues with having a lockdown, I think, and I think we're going to see those. Okay, well, let's just carry on, folks. Okay, so the things I think are important here are the location. The first MTP is a big predictor of gout, and he hasn't got it everywhere else. If he had it in both MTPs, you might think he'd have something like rheumatoid or some other form of arthritis. It had a fairly rapid onset. It's not septic, and it's very important to get a temperature on these people. Because if he's got a temperature, you have to think about, and I was thinking about that with your patient, Hannah, if he hadn't got better, what sort of dangerous things would be coming up in the differential? Do you want to unmute and have a go at that?
Well, yeah, I guess the main one that comes to mind is to rule out a septic joint.
Yeah, because that's an emergency and that's a disaster to meet. We had a guy in our study, his temperature was 37.1, and that was a rule out. We sent him to Middlemore and he actually had an osteoarthritis of one of his phalanxes. So, I mean, sort of interesting. I'd learned to be fussy. When you're really worried about infection, anything over 37, you have to think about. I mean, it's a very low threshold, but yeah. So previous episodes and the fact that he's Polynesian, because Maori and Pacific New Zealanders and it's in about half the families, I would say, have a genetic predisposition. I was telling Hannah, one of the little things I do if I've got a bit of time, if I've got a Maori or Pacific man, and usually men, it tends to affect men, and that's in part due to hormonal things. Estrogen's a protector against gout. Is I'll ask them, if they don't have gout, I'll ask them, is there gout in the family? And none of them have got gout in the family. Alternatively, you have a Maori or Pacific man who's got gout, and you say, is there any gout in your family? Everyone's got it. I mean, it's so apparent. Just try that the next time you're with a Maori Pacific man, or if you've got Maori Pacific relatives, ask them. Should we do a needle aspiration? In primary care, we don't do that. We just don't see enough. It's more a skill for rheumatologists, although Peter Gow doesn't do them anymore, which is interesting. It's not particularly painful to put a needle into a hot, swollen joint. It's more painful if you press it. It's pressure that causes the pain. Actually, a needle going in, although it's terrifying for the patient, you've got a big sore red toe, and here's a doctor wanting to stick a needle in it, you think they've got to be out of their minds. But that would give you the diagnosis, because then you'd see crystals under a polarizing light. You may have seen pictures of that. Okay, so here's the criteria. This is from North America. These are, and if you get a score, I think of 8 or more, you've probably got gout. So serum uric acid above 0.36. Now the nice thing about this guy is he had a 0.58. If he had a 0.34, that could be a bit of a rule down as to him having gout. That would lower your likelihood of having gout. The only proviso there is a serum uric acid taken in an acute attack is sometimes quite low. If you like to think about it, all the uric acid has gone into the joints. He's male, so men get it way more than women, and I'll show you a graph to show that. He hasn't had a previous attack. Did your man have hypertension? Do you know, Hannah? Microphone? Oh, Hannah's talking to somebody, I think. Hannah, did you?
No, sorry. I was on MedTech trying to check if he had hypertension.
But screening and see if has he got a classification or a high blood pressure?
The computer has frozen, so I cannot tell.
Okay. We have joint redness, onset quickly. So he mightn't make it there. So he's got 3.5, 5.5, 6.5, 7. So he's just under threshold. So he may be more of a possible. But the fact, see, if he'd had one before, then he'd be over the threshold. So giving him, what else could you have given him, Hannah? What other, so you could have gave him ibuprofen. So any NSAID will do. None is better than the other.
Yeah.
Helen, do you want to answer a question? Are you putting your hand up for something?
Oh no, there's a little fly near me. It's like a fruit fly.
You should have been super friendly. That's okay.
Oh no, but can I ask how hypertension plays into increasing your risk?
Sorry?
How does hypertension play into increasing your risk?
Nobody knows, I would say, would be the major answer. It may be that a lot of hypertension is treated with diuretics, and diuretics can trigger off gout. Okay, so it's just one of those epidemiological things that we know about, or so greater than one cardiovascular risk factor bumps up your risk, which is interesting because allopurinol probably brings down your CVD risk. One trial of allopurinol versus placebo reduced angina. So it's actually quite a good drug to give people. It's probably an antioxidant, whatever that means, but it does reduce, and it compared to febuxostat, which is the other xanthine oxidase inhibitor, it's actually better at cardiovascular disease than febuxostat. Okay, so that's a clinical score. It's a gem, by the way, so that's one of the advantages of getting a gem. It was a gem a few years ago. I really would encourage you to sign up to the gems. That's not because I write them. It is good for my ego, but it would be. But I think until you're going into your subspecialties, it would be quite handy. It's very general stuff. It's designed for, GPs, house surgeons, etc. Okay. Now, if you're not sure, now with this guy, if he kept coming back in, because it's very hard to do a needle aspiration of any joints other than perhaps the ankle, the big toe, or the knee. You need to have ultrasound guide, and you might actually get it in the wrong joint if you're doing aspiration, because you don't know which joint is bothered. But there is a thing called dual emission CT, and I don't know, you may have seen these pictures, but that's what you get. So that green iridescent is showing uric acid deposits. So the only skill you really need for this is not to be colorblind. It's pretty amazing, isn't it? Isn't that fabulous? Rheumatology has become a discipline via medications with the introduction of hydrocortisone 70 years ago. And now there's all this wonderful imaging stuff that they've got. So it's, and it doesn't have a lot of on-call. It's quite a nice specialty to get into if you're thinking of something that's not going to ruin your lifestyle. Okay. So the differentials are these two things: septic arthritis. You'll be a bit unlucky if you miss a septic arthritis. And there's a thing called pseudo gout, which you often pick up on knee x-rays. It shows up a streak in the tendons. It's a difficult diagnosis. It's also rare. So gout's pretty common. Pseudo gout is less, and septic arthritis is the least common. The only way I've ever picked up pseudo gout is, and it was quite funny, I had 2 knee x-rays in a row with pseudo gout, and I thought the radiologist must be having a special on pseudo gout, sort of 2 for 1. It was really, it really was, I was a bit mind boggled actually. I kept thinking, what's going on here? Is there an epidemic of pseudo gout? Or so obviously got quite a study room there, Lucy, with another screen behind you. Okay, so here's what I was talking about before. So this is the prevalence of gout in New Zealand based on allopurinol usage. So one of the things you can do with big data is you can look at what people are taking. And allopurinol is pretty well only given to prevent gout. It is sometimes given to people having chemotherapy because they get a rush of cell damage and urate in the blood. But this, I'll just point it out to you. So this is men, and this is women down here, I think. No, sorry. This could be women down here. So again, it all goes up with age. That is Pacific men. Sorry, that's Maori men. That's Pacific men. That's overall. That's European, and that's Asian. So much less common in Asian men and women. The biggest number in New Zealand is actually European men because that's the bigger population. But the rates in Maori and Pacific men are very high. So you need to know the difference between rates and numbers. It's like the rates of heart attacks are coming down, but because everyone's aging, there's lots more of them. So you're going to see lots of heart attacks in your career, but it's going to be in progressively older people. When I was at your stage, you couldn't get into a coronary care unit if you were over the age of 70, and now the average age in a coronary care unit is 70. As Rod Jackson says, only doctors got into coronary care unit over the age of 70 when we were house surgeons, so it's a bit more democratic now. Okay, so why does the uric acid, why does the gout attacks get worse as you get older? So here's your man here, Hannah. He's at risk of getting more gout. Why is that? Does anybody want to have a go at that?
Is it reduced kidney function would play a factor into it?
Yeah, absolutely. So what's your kidney function at 70 like compared to when you're 20? Does anybody know?
Quite a bit worse.
Want to have a guess?
60% of?
Yeah, it's about 50 to 60%. So essentially, it's as if you had one kidney removed when you're 70. So a 70-year-old looks like a 20-year-old with one kidney. And so my pathophysiology would say the kidney isn't handling uric acid very well. So it's going to go on. It doesn't end well, gout. Unless you get prophylaxis, you will have more attacks. And as men get older, as you can see, they start taking allopurinol. It's up to 50% in Maori men by the time, 45% by the time they're in their 80s. There's another factor there, and we're going to talk about it later, the difficulties of getting young people, and it's usually young men taking prophylactic medication. There we go. So really roughly think about that. Now that doesn't show up on the blood test. If you see a creatinine go up in a 70-year-old, they've probably got less than 20% kidney function. Mm. So they'll still have normal creatinines, in part because their muscle mass, your muscle mass is disappearing as you get older. So your muscle mass is going down, your kidney function's going down, and it's a bit of a race to the end. Okay. Okay, so from earlier tests, we've got a creatinine of 102, so that gives an EGFR of 70. We have a previous U rate of 0.58. One of the advantages of primary care, although now you can look up test safe and look up previous blood tests. It's a bit clunky. In primary care, it's quick to look this up. In secondary, if you go to the test safe, it's pretty, you have to click through a whole lot of, I don't know how many of you go into test safe, but it's, I find it a touch clunky. So we've got somebody in Colville there. I notice, yeah. How's things up there?
Good. Yeah. Sorry, I just had to figure out how to unmute it.
Easy to talk. Yeah. Well, that's an interesting place to be up there. You know that Coromandel didn't get flu in the 1918 pandemic?
Okay, no, I didn't know
They
that.
blocked the roads, the locals. There weren't a lot of people living there, of course, but as did Australia. Australia stopped ships coming in. They did a maritime quarantine, and they didn't get it till 1919, and by which time it had become less virulent. So social isolation helps. Okay, so to treat an acute attack, these are the things you can do. Any NSAIDs. Actually, interesting, prednisone is as effective as an NSAID, but without as many side effects. Now, you'll come out a little bit frightened of steroids, but short-term steroids are pretty safe. The numbers needed to harm are about 800 to get a fracture. So if the person's a jogger or a football player, I would use an NSAID rather than a prednisone. The other option is colchicine you can give. Interestingly, twice a day is better than 3 times a day. You often, when I was at your stage, we were taught you give it until people have to run to the loo. It creates a terrible diarrhea. And if people have had that diarrhea due to colchicine, they often won't take it again. They're absolutely terrified. It's sort of like an explosive diarrhea. You have to reduce the dose in poor or renal liver function, and you don't give it to pregnant women. We often use this for flare control. Okay, our numbers are up. So now here's the primary care choice. Now you will have seen this table from Nicola, and it's got a whole lot of other things over here. But in primary care, this is all we deal with. The acute attack, we can give NSAIDs, colchicine, or prednisone. You have to give about 40 milligrams, 30 or 40 milligrams of prednisone. That's a pretty big dose, and it messes with people's sleep. Any of you have ever been on a moderate dose of prednisone, it can cause problems. And just be careful, even with short courses, because I famously broke my ankle on 40 milligrams of prednisone. I'd been on it about 4 days and had to have surgery. So I'm personally very frightened of short courses and somebody who's reasonably active. And that was on the death zone of Mount Eden, I might add. So it wasn't exactly a dangerous place. The other thing you can do if you're pretty good, I've done it with knee. The problem is there, you don't want to put steroids into a joint that could be septic. You'll really end up in front of medical counsel. So you sort of have to get the diagnosis, and you could look under a microscope if you've got a polarizing microscope. The lab might do it in 24 hours. And if it came back as gout, you could give it the next day. When it comes to prophylaxis, so when you're starting allopurinol, so these are the drugs you do for prophylaxis. Allopurinol is out and out the most common one used here. If that fails, you can then use febuxostat. It rarely fails. I would say it virtually only ever fails if somebody's not taking it. We do have a man in our clinic, he's a Pākehā man in his late 20s who's got a genetic condition, and he's on about 800 milligrams. And I think he's on febuxostat. He may be on febuxostat now. Febuxostat is more potent milligram for milligram, but it does have a higher cardiovascular risk than allopurinol. There's randomized trial evidence behind that. You can also use probenecid. Now, probenecid you may not know much about, but this is a drug most commonly given with penicillins or cephalosporins to increase the blood level of those beta-lactam drugs. Ironically, this is more expensive than the penicillins now. So when I was at your stage, for gonorrhea, we used to give 3 grams of amoxil and 1 gram of probenecid. It also is a uric acid agent. So if they can't tolerate these ones, you can try that. It's not as effective though. And then there's ones called benzbromarone. I would leave that for the rheumatologist. If you're not getting anywhere with these ones, bail. It's time to bail. I've never put anyone on benzbromarone. It does have some nasty side effects, so so beware of that. Now, when you're giving these, you need to give prophylaxis against flares. We commonly give colchicine because it's probably got the least long-term problems than NSAIDs. And if you just think about the 3 common serious harms from NSAIDs, they are increasing cardiovascular risk, damaging the kidneys, and causing gastritis. If I give an NSAID long-term, I always give a proton pump inhibitor, almost irrespective of the age. Sometimes some people under the age of 30, I don't. But particularly with older people, you've got to be quite careful. They will get GI bleeds. The other thing is to give prednisone in low dose, maybe 5 to 10 milligrams a day. But remember, you're giving that for 3 months. So then you have to off titrate them. I've just got a lady at the moment who's a nurse, and we're treating her for giant cell arteritis. And she suddenly said, well, can I go back to work? Well, no, not if you're on more than 10 milligrams, because with the COVID virus, she's a frontline worker. So she's quite happy to take a bit of time off, actually. That's not a big deal, but it'd be a bit of a problem. We would probably do a fast reduction because she's only been on it about 3 weeks. But she was on 60 milligrams to start with, and she couldn't sleep. In fact, now she's still having trouble sleeping down at 20 milligrams. So I've had to give her sleeping pills. So it's pills to counteract the pills of side effects. Okay, so that's the primary care view.
Interesting point, Bruce. That's not one that we thought of, but that patient that I talked about in my case, we did consider prednisone, but he's also a frontline worker, works at the airport, and a customer service face-to-face role. So he's somebody who'd be, you don't want his immunity compromised at the moment.
Well, interesting. Some of those frontline, I don't know how much PPE they get access to, but they're actually as exposed as doctors are if you're seeing one person after the other. People are worried about our health, but those people's health. I know the supermarket people are all gowned and masked now, but appropriately so. Okay, so this is the management of gout. So we suggest prevention, and this is a rule that's sort of made up by wise people, greater than 2 attacks a year. Remember, this is particularly difficult in young men, and I'd like you just to think about why is it difficult to get young men to take medication for the rest of their life? And I'll break that out for a question in a moment. This will decrease the number and severity of gout flares. It'll reduce damage to joints. It'll probably reduce damage to kidneys. It will reduce cardiovascular risk, but we also have to check for comorbidities because this is in a population at high risk of cardiovascular disease. So how do we start low dose? We started with low dose. So it's about a 3-month titration. If your kidneys are good, then you can start at 100 milligrams. You drop the dose down to 50 if the kidneys aren't so good, and you give 50 alternate days. It's not toxic to the kidneys, and it probably wouldn't matter not to do that, but that just seems to be what's done. What you don't want to do is give them 300 milligrams, a big dose to start with. 300 is a pretty common dose, and in New Zealand it comes in a convenient 300 milligram pills. So there's 100 milligram pills. So they take 100 milligrams for one month, 200, that's 2 pills for 1 month, and then they go on to the single pill at 3 months. If you give 300 milligrams stat, you can cause a terrible skin condition. It's as if the skin it's like somebody's been in an atomic bomb. The skin just peels off them. And that's about 1 in 10,000 people get that, and about 1 in 30,000 die from it. I met a GP in Tiwamutu. He was an older guy. He'd had 2 in his career. So he was a little bit gun shy about allopurinol. So you've got to weigh that up against the social harm of having gout, because you can't work if you've got gout, and you're going to be pretty grumpy around your family, and people are pretty happy to be on it when they've had lots of attacks because they can't go to church, they're grumpy at family functions, they can't go to the shops. It's pretty debilitating. So our target is 0.36, and we give colchicine for 3 to 6 months to prevent flares. So it's a lot of pills. In the blister packs we give, it's 40 milligrams of prednisone, dropping down to 0 over 2 weeks, and then 100 milligrams of allopurinol and 500 of colchicine twice a day, once or twice a day. If they get diarrhea, drop back to just 1 colchicine a day. So remember, start low and prevent flares. That's low dose. Take home message, always start with a low dose. The other thing is if you give 300 milligrams, you will precipitate gout. And in some parts of the Samoan community where they've been given sometimes high doses of allopurinol, this was some years ago, they thought it caused gout, and they were correct. It can cause gout. So you need to start low, prophylaxis, and then so it's a bit of a circus to get people up to a high dose. So you have to sort of be in there for the long haul. We now have pharmacists who do this for us, so that's made that easier. And the target is below 0.36. Having said this, if you're below 0.42, you're pretty unlikely to get a gout attack. If the key thing about the blood test, the most important thing is to take the medication. Then you can worry about the blood test. So long as they're taking the medication and not getting gout, I don't really care about the blood test. But if they start getting attacks and the uric acid is below 0.36, you need to rethink the diagnosis, okay? So you've got an older person with a sore big toe, it could be osteoarthritis, which is the other thing in older people. Okay, so the comorbidity, this guy's obese, you want to check if he's got diabetes. Does he drink a lot of sugary drinks? Okay, so if you drink soft drinks with fructose in them, that increases your gout risk. My 35-year-old with the claw hand, used to drink 3 bottles of, big bottles of Coke a day. The diet stuff is good. The diet stuff actually reduces your risk, will reduce your uric acid. Alcohol, it does seem to be more beer than other things. It may be something to do with the hops in beer. Cardiovascular medications, in answer to Elizabeth's question, I think it was Elizabeth's question, and high blood pressure. Urate elevating medications, diuretics. Now this is the problem. The rheumatologists hate diuretics, and the cardiologists love diuretics, and I love diuretics. But when it comes to gout, you sometimes have to be a bit cautious. I've caused attacks of gouts, and then chronic kidney disease for the reasons we talked about before, because you want to have good kidney function. Okay, so this man was treated initially with diclofenac, 50 milligrams 3 times a day for 2 weeks, and then he was started on allopurinol. This was titrated against blood tests, and he was given colchicine BD for that. Can you see that thing at the bottom there, the blister pack for the first 3 months? And then it's got Gout Happy Feet. Can you see the Gout Happy Feet?
Yeah.
Good. Okay, Gout Happy Feet is a Goodfellow website with tons of good handouts for patients. And they're written in English, Samoan, and Tongan. And they're written, some of the non-pharmac ones are written at a health literacy level that's appropriate for people who don't have high health literacy. I had a funny experience. I was in Grey Lynn Park a few months ago, and a Pacific Island looking man came limping past me. And I said to him, "Oh, have you got," I do this in public, I shouted out to him, "Do you have gout?" And he sort of looked at me and said, "Yes." Sort of like, "How did you know?" Well, I could tell by the limp and the fact he was specific. And he was just visiting New Zealand from Tonga. And so I emailed him the Tongan, and he was quite pleased about that, and told him that he could use anti-inflammatory, because he wasn't sleeping at night. He was very pleased to have a bit of free medical advice. So I was his first medical consult in New Zealand. So if you see a Pacific Island man limping, go and tell them there is a treatment. I call it the Good Samaritan syndrome. And I think it's good to spread your medical, you've got a lot of information in your heads now that can be helpful to people. Okay, so precautions with colchicine. The way I was taught to use it killed a few people. So we don't suggest that these days. Maximum 4 per day to treat acutely. You often only need 2 to 3. Check drug interactions and don't give it to pregnant women. Unlikely to get gout. I've never seen gout in a pregnant woman. And it is very common in women of childbearing age. It's more a condition of older women. Okay, so primary prevention. This was his total cholesterol. So anyone want to tell me what the risk there is? So his total cholesterol is pretty good. HDL 0.96, a bit low in his ratio. What are his CVD risk factors there? His risk back in those days was 15% on the Framium calculator. Do you remember what would be driving that? There was something in his history that would be driving that. So what there, somebody would like to turn their microphones on and answer that? Give Hannah a break.
I can't remember if he was a smoker.
Yeah, he was a smoker. Yeah, so that's a problem. Yeah, so being a smoker, if you stop smoking, it halves your CVD risk. Literally, within a few months, your CVD risk will halve. You take smoking in and out of the equation, and you'll see it drop. So the biggest thing you can do for people in life is stop them smoking. What else there? What else is? Somebody else like to have a go at that? We've got 45 people online now.
I'd say it's hypertension.
Yep, his hypertension, sure. What about his lipid profile here? There's a couple of things there that you would want to pay attention to. What about that?
It's low. His HDLs are low,
Yeah.
right?
Well, that's a risk factor for CV disease. There's no drug treatment you can do for that, but does anybody know what physical behavior you can do and what things you can eat that will improve that? Any suggestions?
Eat plant sterols like margarine.
Yeah, actually probably more the olive oil. Margarine I think is neutral on HDL, but olive oil and avocado will increase it. It's all the expensive stuff, sadly.
Things with high dietary fiber like oats and bran.
I think they help a little bit. The classic things are nuts. Actually, alcohol. If you see a man with a high HDL, ask them about their alcohol. A lot of women have high HDLs, and that's estrogen genetic factor. But if you see it in a man, patients who are heavy drinkers, and that's probably what prevents CVD in some of them. Some of them have very clean arteries. And then, of course, the ratio, which is that divided by that, that's above 4.5. His risk at 45 millimoles does not increase his risk. But in a young man like he is, now he's in his early 40s, this is the guy to watch because he'll rush into diabetes. This guy in a couple of years could be fully diabetic. His pancreatic function is starting to, he's down to about just over 50% beta cell function at that level. And he could go, he could have a forest fire and you'll need to treat his diabetes. Okay, this is the old CVD tables. They approximately double your risk of CVD. Now we've got the New Zealand equation, which you can do on the Canadian website, the Therapeutics Collaboration website. I will have shown you how to do that in fourth year. You can get the New Zealand predict equation there. That's Rod Jackson's equation. I don't know how easy it is to get in New Zealand unless somebody knows. If somebody knows, let me know. And this is the Manage My Numbers, I think it's called. This is the great ones. If somebody keeps smoking, you can show this is what's going to happen. It ain't going to end well. Of course, your cardiovascular risk goes up with age, and this is the medication threshold here of about 15%. When medication, where you become a bit more pushy about medication, down here you might dance with lifestyle, but your benefits up here start to become significant. Your numbers needed to treat are getting better the higher you go. But this is a great one for the smoker. If you stop smoking, it'll come down here. Any questions on that? I heard a voice. Okay, so we consider his total risk smoking, blood pressure lowering, so you might want to give Cilazapril, which is going off the market shortly. Avoid diuretics, so I wouldn't give the old Inabase Plus, which is Cilazapril plus hydrochlorothiazide, although you're going to treat his gout, so it probably doesn't matter, actually. You would only do things about it. His risk is 15%, so you might want to have a discussion about his cholesterol. But of course, if he stops smoking, and then you want to see if he can prevent his diabetes, The options for that would be exercise and diet. Easy to get patients to do exercise, hard for them to diet. People find dietary changes pretty difficult. But for his diabetes, you could give him drugs. Any of the diabetes drugs like metformin will prevent people going on to diabetes. Any diabetes treatment drug will preserve beta function. You remember from the Scandinavian study I showed where lifestyle and diet trumped drugs, metformin trumped nothing. So don't get too much in love with your drugs and devices. Remember that actually good old lifestyle. The problem with lifestyle, it's often easier to take a pill than to make changes in your lifestyle. We're creatures of habit, unfortunately, modern humans, and lifestyle change is difficult. Diet and exercise. Now, a lot of younger men don't want to take drugs. They want to do lifestyle, but they eventually give up and go on to diet. So what are some of the reasons why your 25-year-old man is probably not going to take the allopurinol for the rest of his life? Can we have a few thoughts about that? Hopefully you're warmed up to that one. I would say a woman would possibly be more likely to than a man. I've got some data on that, and that's my clinical experience. Any thoughts, Helen?
It's for everybody. It's hard to take something every single day and to remember to.
Yep.
Then maybe for young men, this is just hypothesizing, that there is a mentality that it makes that they feel they see themselves as weaker if they're taking medication every day.
Yeah, yeah. They're not as social. They don't look after their health as well. Men in general don't look after their health as well as women. I mean, if you look at the numbers in general practice, it's 2 to 1 in terms of the patients you'll see. Those of you who are seeing patients at the moment, it's about 2 to 1 men to women. It balances out as they get older, but of course there's fewer men around as you get older because the men are dying earlier than the women. Yeah, so it may seem unmanly to take medications. Women often have experience, say, with oral contraceptives, taking pills every day. Men haven't had that experience. So it's pretty hard. Don't be surprised if your 20 and 30-year-olds don't take your medication. I was telling Hannah my little joke that this applies to men, not so much women. You spend the first 40 years of your life trying to shorten it, and the second 40 years of your life trying to lengthen it. So this guy's just past the magical 40. And believe me, that's true in life. Getting people to take medication over 40, because they're starting to think of their mortality a bit, you know. The Grim Reaper is they will have had a few friends who've got serious. You often don't have friends I didn't have any friends get serious illness until I was in 40. And now at my age, I've got lots of them getting serious illness. So it's downhill from here for me, but you've got a way to go, hopefully. Okay, lifestyle versus drugs. How hard do we push for 0.35? I'm getting the rheumatologist to get a little less obsessed about targets. I'm interested in behavior change. If you're taking 300 milligrams of allopurinol every day and you're not getting attacks over a couple of years, I really don't care about your blood test, and I'm not going to push you to go and get it if there's no other reason to get it. You're supposed to have a blood test every year. That's made up. A lot of things in medicine are made up. And why should somebody have a needle in their arm if they're fine? So you can check that out with the patient. But often as they get older, they're going to need blood tests for everything else. It's nice to know, but you don't need to know, okay? Nice to know, not need to know. Very much a primary care view of the world. It's nice to know these things. We don't actually need to know. It's the behavior you want. And this man got no attacks of gout on his, his level went to 0.35 and he got no attacks. So there's the Auckland Regional Health Pathways. Are you all using them? Thumbs up for everybody. Let's just see if we can have a gallery view. Yeah, go for it, Hannah.
Oh, no, I just could never remember the password for health pathways, but I'll take a
Connected and
screenshot.
healthcare. And because you're all Auckland students, I can tell you, no one's going to send me a sniffy email telling me off about that, which happens when we do webinars, which go out to the whole country. Somebody sends me saying, don't give the password out, which I think is crazy. This is public money that's paid for this, but because the Canterbury region developed them, they're keeping a control on the IP. And I think as a taxpayer, I sort of object to that. But anyway, that's more in the political realm than gout. Let's get back. So gouthappyfeet.com, lots of good patient resorts there. And we've got the blister packs there. The blister packs, some pharmacies will know the blister packs. There's a blister pack 1, 2, and 3, depending on the EGFR. Have a little look at those. You don't give prednisone to diabetics. I famously gave a type 2 insulin dependent blind 80-year-old an injection in her knee for her sore knee with 40 milligrams of prednisone, and I tipped her into a hyper glucose situation. She ended up in hospital. So just be very careful with diabetics, particularly if they're on insulin. Be very careful giving them oral prednisone of any dose. Get some advice. So Gout Happy Feet. Okay, the doctor bypass study. So this is a program that we do in our clinic. It's done in a lot of clinics. So if you're in an Auckland clinic in South Auckland, so this is a gout patient, known gout patient who's dropped off the allopurinol. We get a nurse to phone them up and say, would you like to go into, it's called the OMG program, which is an unfortunate acronym you'll appreciate. It means Own My Gout, not Oh My God. So yeah, somebody didn't understand text abbreviations who came up with that. So it's Own My Gout. Would you like to go into our program? You don't have to come into the practice. Just go to the pharmacy. We'll drop a prescription off and you can pick up your allopurinol. Would you like to do that? And about 30 to 50%, usually men do that because these guys are working. My PhD student spoke to a man in Papakura. He's a Maori man. He gets a ride to work in Helensville to work on a road gang at 6 o'clock in the morning. He works on the road gang all day and then he comes home and gets home at 7 o'clock at night. How is that man going to get treatment for his gout? He can't get to see a GP, hard to get to a pharmacy, and hard to get to a lab test. So he's been on allopurinol. We assume his kidney function's okay, that he's not a John Lomu and it's gone off. But just think about it. Some of these people have a lot of problems getting to healthcare. Now, what happens to that man if he takes a half day off work? He has to take his own car to work. That's going to cost gasoline. What are his workmates? What are the blokes on the work gang going to think of him going to see his doctor? I'd like a few answers on that. And he's going to lose half a day's pay. So this gets around all that. He can go to the pharmacist. The pharmacist does a skin prick and gets uric acid and then up titrates him to 0.36 and then gives them back to us and we just keep them going. So it works very well for somebody who's just on allopurinol. So any thoughts about that, man? Have you seen anybody like that? I call it the shadows of inequity. You know, you can go to the doctor anytime you like. You just have to ask your clinic, I'm going to see the doctor, and you'll be allowed to go. In the hospital, that's the case. But for some people, it's not so easy. So any thoughts or comments on that guy's experience? I mean, it sort of horrified me. I sort of thought, gosh, I've never really thought about that, that would happen. Any...
I just think that's not an uncommon situation for a lot of people.
Yeah. Have you come across it?
Yes.
Yeah. And what sort of situations have you come across it?
Well, it clinically, but also I know my brothers who work in construction, they work 12, 13 hours a day, every day, including, well, not Sunday, but including Sunday. So it's very hard for them to go to to see a doctor.
And what would their workmates think of them taking half a day off to go and see the doctor? Would they be super supportive?
No, I don't think so. I mean, any injury or illness that they get, they avoid the doctor, they go to work and they just kind of trudge through it.
Yeah. No, it's not men aren't particularly supportive of other men and healthcare seeking. So just remember that, you know, and also the team, they depend on that guy. You know, he's part of a team, and he's out of it. Somebody else has to do his job. You know, there's a whole lot of things going on there, and if you don't think about them or you haven't had any exposure to it, yeah. So that's the only problem. So I call this the doctor bypass study. That's my alternative to OMG, but it does sort of describe what's happening. And you know, this is your commitment to equity, really, is supporting this sort of thing. And I think what's happened with this whole lockdown, I call it the burning platform. We've made massive changes because we've had to, and we really have to think about how we do healthcare. I mean, traditionally doctors would say, no, you have to come in and see me. We need to check your uric acid and your kidney function before we can restart your allopurinol. Now, I think that's an unnecessary step, as does this program here. It's run by the DHB, so the pharmacists get funded for doing it. And the pharmacists love it because it gives them a bit of clinical work to do rather than sort of handing out pills to people. So actually, it's satisfying for them. But we've got about 50 or 60 patients. I guess you can't pop down to the pharmacy and see how they do it, Hannah, these days because of social distancing. But anyway, you might like to talk to the person who, they've changed down there, but you might want to phone them up and just have a chat to them. They really like it. Okay, so the take-home message here is to know how to deal with the acute flare, to know how to use blister packs, start low, go slow. And then I've got a few cases here to talk about. And this is the classic man here. So this is your 25-year-old man, presents with gout, strong family history, 2 attacks per year. We've talked about the reasons why he won't take medication. Did I talk about the GP who makes her patients earn their allopurinol?
No.
The GP near us who won't give allopurinol until people have had a few attacks and are really, really struggling with it. That may seem a bit tough, but you can understand her experience. She will have gone through this up-titration thing 2 or 3 times with somebody, and it gets a bit frustrating because it's quite a complicated, slow process. So she likes them to have a few attacks. I don't know how many, but I find that a little bit tough, but I can see where she's coming from because it is frustrating to have to go back to square one. And I'll try and show you my picture of my gout, my man with a gout walk. Okay, so here's a tricky one. 50-year-old man has blood pressure 180 on 100, had an MI 2 years ago. He's run out of medication and needs to restart. You've given him losartan, 50 milligrams, and hydrochlorothiazide. So that's the new alternative to silazepam plus. So that's an ARB. The nice thing about losartan is it reduces your uric acid. It's the one drug that will reduce your uric acid. I think it's the only ARB that does it. He develops gout. So what are you going to do with this guy? Any suggestions? You feel a bit bad that you've caused his gout. He's never had gout before. You're going to leave him on that? I mean, he'll get better with NSAIDs or steroids, but what are the alternatives?
Could you just keep him on losartan purely, or does he need to have a
at that level of blood pressure, he's going to need at least 2 medications. I would say that this is a wee challenge to you. If you see somebody whose blood pressure is controlled on a single medication, it's below 130, you would want to wonder whether they truly have high blood pressure anymore. Because people go in and out of blood pressure. We don't quite understand that process. I mean, it gets worse as you get older on average. He's going to need something else. So what could you add to an ARB?
Maybe a calcium channel blocker.
Yep. Do you have a favorite? There's 2 common ones we use here, which are good for blood pressure.
Amlodipine or felodipine.
Yep. What's the common side effect of those things? Tends to turn up in summer.
peripheral edema?
Peripherals.
Yeah. Swollen ankles, yeah. And if it's a dose-related thing, in my experience, with felodipine, once you go over 5, I was going to say it's almost inevitable, not quite inevitable, but I spent a summer a couple of years ago switching people from high-dose felodipine to low-dose felodipine, which is why I like diuretics. Diuretics, other than electrolyte dysfunction, are very well tolerated, as are ARBs. I stopped giving ACEs quite a few years ago because the ARBs are now fully funded and you don't get the cough. I've seen so many people, with about 20% of people on ACEs get cough. I just wouldn't bother with. I mean, they're pretty well interchangeable. They're acting on the same. The evidence, there's a bit more evidence for ACEs than ARBs, but there's so much evidence about both of them that, yeah. So, okay. So
it's just about that. Do ARBs have the same cardioprotective, renoprotective effects as those?
They have. There's one or two things there's an absence of evidence for, but with everything it's been checked against that ACEs, I mean, ACEs have been around longer, and the reason we didn't do ARBs was because of cost. But, you know, the nice thing about practicing in New Zealand, if Pharmac funded fully, don't worry about the cost. They've got it sussed, okay? They've done the rationing, a really nice thing about practicing here. In other countries, you have to think, how much is this costing the patient? Whereas here, and once it was fully funded, I went straight over to it. But literally, I've just seen people coughing for years. And it often doesn't drive them crazy, it drives their family crazy. You know what it's like to be around somebody who's coughing? It's pretty irritating, isn't it? It sort of really winds us, turns on our sympathetic nervous system. Okay, so you add felodipine, you give him 5, he doesn't get swollen ankles, blood pressure's still 160 on 100. What are you going to add to that? What's next? Without giving a diuretic. Anyone want to suggest?
Have you talked to him about lifestyle measures?
Yep, you want to try lifestyle measures. It's not going to do much for that blood pressure, unfortunately. Well, if he lost 10 kilograms, it would. But good luck getting anybody to lose 10 kilograms in your whole career. When you retire, you might have got 5 people to lose 10 kilograms and keep it off. I haven't yet got 5 people to lose 10 kilograms. And boy, have I tried. Other than bariatric surgery. Yeah, so look forward to that, guys. But you're right, yeah, try lifestyle. Exercise will help. Exercise might bring it down. A bit of lifestyle and weight loss might bring it down to 160 on 100. It's not going to bring it down. And remember, he's had an MI. So think of the sprint trial. You want this guy's blood pressure below 130.
You could add a beta blocker.
Yep, you could add a beta blocker. Do you have a favorite?
Metoprolol.
Yep. I tend to use bisoprolol because it only has 4 titration levels to get to a maximum dose, whereas metoprolol has 6 levels. And patients think you're poisoning them if you keep increasing the dose. So, and metoprolol is in rare supply in New Zealand. Bisoprolol's not, and they're both good for heart failure. So I'd use bisoprolol, but you're right, metoprolol would be fine. The other option would be spironolactone, but that's probably going to cause the gout as well. So let's say all that fails. You might then want to, so I've suggested giving him perindopril, which is a long-acting ACE, or candesartan, which is a long-acting ARB, rather than losartan, it's longer acting. That may be better, because that's giving you a better nighttime drop. And you've got the nocturnal notch where people whose blood pressure doesn't go down at 2 or 3 o'clock in the morning have worse cardiovascular outcomes. And that may be why people who take their blood pressure medication at nighttime do way better in terms of cardiovascular outcomes than people who take it in the morning, which is interesting. There's 2 trials on that now, both done from the same center in Spain. We're all waiting for more studies. And they weren't they were circadian rhythm units rather than, but they were big trials. They had cardiovascular outcomes. So I've added amlodipine, bisoprolol. You don't necessarily go to maximum dose. So the key way to treat hypertension is to give multiple low dose. And there are a few trials now of 4 drugs all at low dose, because the benefit doesn't go up with dose, but the harms do. So you're much better to give an extra low dose than to double the dose of something, okay? Bendrofluoride should be stopped. We should be switching to either indapamide or chlorthalidone. You'll have heard me on chlorthalidone. So let's say you get down to 155/95. You're starting to write. You don't want to give an alpha blocker because alpha blockers have no. They're significantly worse than chlorthalidone in terms of heart failure. There's no cardiovascular outcome studies on alpha blockers. It does lower blood pressure. So what might you want to do if you're going to give a diuretic? You want to give chlorthalidone because Bruce Arrow likes it. So how are you going to get? And it's got the best evidence base for it. It's got a good evidence base as ACEs, and way better than bendrofluoride, which on its own doesn't seem to alter cardiovascular outcomes. So although 87% of New Zealanders are on bendrofluoride, it's actually probably the wrong drug. Maybe an absence of evidence, but the 2 trials that have been done on it showed no difference. So what could you do with this guy? You want to give him a diuretic. You don't want to precipitate gout. What might you do?
Could you treat him prophylactically for gout?
Yeah. So you might want to start him on allopurinol because he is a Maori man. He's 50. He's already had a heart attack. What are his chances of getting more gout?
High.
Yeah, probably he's going to get gout. So that would be an option. If you can get him taking that many pills, and other pills probably not going to make a huge difference. We're all rather hoping the poly pill will be funded in New Zealand. That's an ACE diuretic and aspirin, or ACE beta blocker, statin beta blocker and aspirin. We're hoping Pharmac will fund that, which would be really good in this guy's case. Absolutely perfect, because you're probably getting a bit of a feel for pill load for people these days. My record was 20 pills for one patient. I got a pharmacist in to review it. She got it down to 18. Each one of those was evidence-based. I think if the patient knew the absolute benefit of each drug, she probably would have stopped half of them. You know, some of them have got like 2 to 3% absolute benefit. That's a lot of pills. And, you know, I'd be interested in some of your thoughts about the pill load you're seeing with patients. Any thoughts on that? Unmute if you're going to come on.
I'd say here at this practice, I've probably noticed not as big a pill load as I might have expected. Probably most patients. I think you get used to seeing people. I think most of us have just come off general medicine, and so your patients often present with a really long list, and so it's quite nice coming to general practice where most people, on average, have, you know, not so many.
Is that other people's experience? Yeah, well, that's good. That's good to see, because I get a bit horrified when I see people's pill load. And I do try. I like the combination drug, the losartan hydrochlorothiazide, although Dr. Van der Merwe at Waitemata thinks it's too low a dose of thiazide. You can give a double dose. You can give, and that way you'd be giving 25 milligrams. But I find it a pretty potent lowering of blood pressure for a single pill. You can often get 15 to 20 milligrams. So that's often my first choice. I wish there was a chlorthalidone with a ACE or ARB. There are some overseas, and there are some poly pills with that combination. And interesting, chlorthalidone was the drug used in the SPRINT trial because the Americans have finally realized that on its own hydrochlorothiazide needs to be given in very big doses, and that chlorthalidone milligram for milligram is a better diuretic. So, and people are slowly coming, Hari Talija here at Middlemore, the renal guys at Middlemore are very fond of chlorthalidone, and of course they see the complicated. So I'd say join the chlorthalidone support club. We're getting more members. Okay, so you could start the diuretic before that. You've got a patient with an EGFR of 30. What dose of allopurinol would you give, and what would you give to treat the acute attack? in this guy. Let's say it's a man.
Would you give prednisone to treat?
Yeah, good one for prednisone. Prednisone's a good option if you're pretty sure it's not septic. They will feel better. Anyone here ever taken prednisone? Yeah, how did it make you feel?
Well, I was on it for 3 weeks post sinus surgery. It was like 40 milligrams, 30 milligrams, 20 milligrams over the week. It made me feel a little bit elevated and hard to sleep. I didn't really enjoy it.
People go manic on it, so it does give people a boost of energy. It's in some of these pills that come in from Asia are laced with prednisone. These energy pills. So you've got to be I say to people who take these things we don't know about, I say, look, I know nothing about them. A, I don't know if they work, and B, I don't know what's in them. What could harm you? I mean, if you're taking prednisone and feeling terrific, that may be good for the first year or two, but really bad for your health long term. Yeah. So a steroid would be quite good. You could give colchicine in that situation as well. A bit of a worry with the EGFR, but it's not particularly renotoxic. What dose of allopurinol might you use in a 30 mils per minute EGFR? Any suggestions?
50?
Yeah, or 50 twice a day, 50 every other day. I think it's usually 50 every other day. They do say if the EGFR is below 30, call a rheumatologist, but I think the rheumatologist would just say what I said, really. I can't see what else they would do. Okay, so let's say you want to start allopurinol and the patient can't take an NSAID or colchicine. What could you take for prophylaxis?
You could take.
About the probenecid that we mentioned earlier.
Yeah, probenecid, that's still going to cause, that's more a urate lowering drug. And given that could trigger off a gout attack. So you've got potentially the same problem. So it's stopping the flares. So that's the language the rheumatologists use, preventing flares. So what's the other drug we can use for acute attack?
You can go low dose prednisone.
Yeah, 5 to 10 milligrams, but you're going to be taking it for 3 months. So what's the deal at the end of that?
Taper it off slowly.
Yeah, so then you have to taper it off. It takes about 2 to 3 months to flatten the adrenals. So in a month, technically, you can't suppress the adrenals permanently. But of course, nobody quite knows the answer to that, and you don't want to be the doctor putting somebody into an adrenal crisis. So after a month, I would start getting worried. So you have to bring it down like by a milligram every 2 to 4 weeks. So it's a pretty slow process, but at least you will have got them on the allopurinol. And I've done that with a guy who was in heart failure, he was on diuretics. He'd had colchicine and it had given him that diarrhea and he wouldn't take it. He was absolutely adamant, I will not take that drug, do not even, and I've misspelled colchicine there, by the way, sorry about that. We then put him on prednisone and couldn't take NSAIDs because his kidneys were wrecked, and we got him on allopurinol. So that was great. And that's, a lot of GPs have given allopurinol during acute attacks. The rheumatologists all said you shouldn't do it, but there's now been 3 randomized trials, including the one that Nicola Dalbeth and I did, and nobody got an acute attack. So there's now 3 trials of that. 2 have been published. We haven't published ours yet. Yeah. So any questions on gout there or anything else? Any general questions, hypertension, cardiovascular disease? Any burning questions that people would like to ask?
I just had a question around colchicine.
Yep.
It might be more of like an emergency doctor's perspective, but I have heard that there was kind of a movement away from colchicine because of its high risk of overdose or toxicity. Yeah,
I think if you keep the dose low, like 1 to 2, I've never gone above 2 a day. I guess the emergency guys may see more of the toxicity. You got to remember there's really different views of the universe from different settings. So emergency room doctors might see somebody who's overdosed on them, in fact. I've never seen that happening. But I would just keep it low. 1 to 2, I think, is interesting that 2 a day is actually more effective than 3 a day and got fewer side effects, which is unusual because usually you get more benefit with a bigger dose. Yeah. So people like Nicola Darboth are still. It's the best of a bad lot, really, is the issue. You probably wouldn't feel that happy about taking NSAIDs for 3 months unless you had to. I mean, NSAIDs are really good painkillers, but they do. I've seen a few people knock off their kidneys. They're 50-year-olds with bad kidney function, and the only thing you can find is they take a lot of NSAIDs. And sadly, it's in the Maori patients, and it's not necessarily for gout, but so I'd be. Yeah, so it's the best of a bad choice, really. 3 months of prednisone's a problem. 3 months of NSAIDs is the problem. Yeah. So I'd say the standard advice still is colchicine, as far as I'm aware. Any other questions on gout? Hopefully you feel comfortable and confident with it. And sorry about the groups. I think it was because people left. You ended up on your own. So I hope you're able to meditate and follow a bit of Tony. Any other suggestions for tutorials? I don't know how many more weeks you guys have got because you're in different sequences, but any other topics? If I can't do them, I might be able to get somebody to do them. Anyone got burning common topics, primary care topics?
Maybe like something kind of like a general pediatric tutorial, just on like kids in primary care. And if they're coming in for kind of a health check, what you would be your general look over.
We did a webinar a few weeks ago on the 6-week check if you want to see it. I saw Karen Hoare to do that. She's a pediatric nurse practitioner married to a pediatrician. She's very good on that stuff. She could maybe talk to you about, have you all got how many more weeks have you got? The 6 years have got, how many weeks? 3 more weeks. And the 5th years, how many have you got?
We just started.
Okay. Yeah. So we could maybe Friday at 11 o'clock, maybe. Was that a good time?
Yep.
Now, how's your workload going? Do you feel like is it manageable? Too much, too little, just right?
Are you talking to the 5th years?
Yeah, probably the 5th years mainly, because the 6th years should be out in practice, unless you're in lockdown.
I feel it's okay, but I made some of my tasks for my learning outcomes a bit long. So I feel like I created more work than necessary for myself.
Self-inflicted learning. Well, you'll know more at the end, I guess, won't you?
Yeah.
Good news is you're going to be better. Yeah. I mean, it is an opportunity to direct your own learning, but it's been very strange for us getting stuff online. Is there anything else? So I'll try and get Karen to do next Friday at 11 o'clock. I might join that because it's pretty. One of the things as an older male doctor, unless I'm doing an acute clinic, I tend not to see. Tend to see younger patients. Your patients age with you. You may have heard that, so I tend to have a bunch of older people who are very nice. But yeah, okay. So I'll see if Karen will do that. Any other topics? Some dermatology topics?
Oh yeah, I'm always interested in dermatology. Yeah.
How about I see if Paul Jarrett will do something? How would that be?
That'd be fab.
Yeah, that would be great.
Paul's customer. Do you know Paul?
Yeah, Paul Jarrett.
Yeah.
No,
I'll see if he'll do one. Anything else like managing cardiovascular disease in primary care?
I would like a refresh of that. That would be good.
Okay. Yeah, one of the things I've realized through all this, actually, refreshers aren't such a bad thing. Like going over things, it's almost as if I just watch a guy who trained me in acceptance and commitment therapy, and I watched him do an interview. I've seen him do it many times, the same one. And I think I'd got to a level where I was ready to learn something new. Like my knowledge had got to a level where I could take in the key messages he was taking. And I think that's what happens to you folks is, like Hannah, you've now seen a patient with gout. So now you're tuned into it and you want to know a bit more about gout, even though we told you everything about gout in 4th year.
I think, to be honest, I don't know, speaking for myself here, but I'd say that I've retained very little from lectures in the earlier years, even in fourth year.
Yeah.
And probably most of what I know comes from clinical attachment and seeing it.
Sorry. Yeah, no, I found it a great relief getting into the clinical years because I had coat hangers to hang things on. I found the first 3 years a nightmare trying to remember things. The Krebs cycle, it went in and out. But I've never had to, I have to say, and I've never had to, Warwick Bagg says he uses the Krebs cycle every day. Mercifully, I never have to use the Krebs cycle, and I never have, and I can't see other than being an endocrinologist. So if you've got antibodies to the Krebs cycle, don't do endocrinology, would be the take-home message. But if you love the Krebs cycle, alternatively, do endocrinology. Okay, well, I'll try and line Karen up next week. I'll get you something, and then maybe the following week, Paul Jarrett, and then the following week, maybe, or we'll do cardiovascular disease. I don't know what Paul's doing at the moment, but we probably have 1 million people on it. I think every GP in the country would love that. Dermatology really gets GPs. We could get 1,000 GPs on for an hour with them. GPs love dermatology and love talking about it. Okay, well, nice to talk to all you guys, and thanks.
Thank you very much.
Okay, we'll see you.
Thank you very much.
Okay.
Thank you.
Thank you.
Thanks, Bruce. Thank you.